And then finally, some pitfalls, more specifically for AirSeal. I think we have advantages. We have the inherent stability of the robotic vision compared with a stable but lower pneumoperitoneum. And I think the lower is very important. Put the pressure when you're doing your transection at 8. Don't do parenchymal transection at 14. You will have gas embolism, that's for sure. So you have to adapt. It's a stable pneumoperitoneum. You can put it at 7 or 8. If you have some bleeding, you can use the suction. You will have 7. No worries, you will have a stable view. So for mobilization of the liver, I might use 12. For transection, we go down to 8. We even go down to 6 or 4. I will show you a case we did last week. I had a tear in a hepatic vein. We lowered the pressure to 4. We did a suture. We did an apnea maneuver to get a stable view, because this is what happens in patients. And this is a very nice illustration. You have a patient with a pneumoperitoneum. That's your environment. You're working in the bubble of CO2. You have a hypovolemic system. So your anesthesiologist does hypovolemic phlebotomy or in any way pharmaceutical. He causes a low CVP. So if you're pushing CO2 at a pressure of 15 in your abdomen, you have a hole or a tear in the hepatocaval confluence, you will have CO2 embolism. If you're working at very low pressure, chances are very low you get into problem. So this is what can happen if you have a tear upwards there at the tumor at the hepatocaval confluence. You have a big hole immediately, CO2 is pushed into the heart. So the hepatocaval confluence is the enemy of high pneumoperitoneum. If you're working high up in the liver, lower your pneumoperitoneum. I will show you a video. So this is actually the dynamic system, high CO2, the pressure at 8, hypovolemia, inspiration, expiration. This is the environment where you're working in. So that's why the communication with the anesthesiologist is very important. This is actually the video of the case last week, very high HCC, very large HCC high in the liver, involved the left hepatic vein, involved the middle part of the middle hepatic vein. And I pushed the liver to the left. So I opened the book and I even put a marking on the surface, but due to the fact that I was pushing on the left liver, the marking didn't correlate with the region of the middle hepatic vein. So you will see the vein is open. I take it, I close it with the sealing device. I ask the pneumoperitoneum to lower to a pressure of 4. So get it down. You will have an excellent view. I open a trocar even to 4. Once everything is stable, the pressure is at 4. I get the suture in. I ask for an apnea to get a stable view on the venous tear. We close it with a barbed wire. I like to use those fill block wires, not V-lock, but fill block, you know, with the knot in the back. You don't even have to put the needle through it. So immediately you can close the hole in the vein. You can see it up, apnea, no movement. And you don't need to put a knot, 2 stitches, and then a hemolock on the wire, and it's closed. So that's how you should communicate. If you're in trouble, just ask everything to adapt. Don't panic. And then you just solve the problem.